Okay, my name is Nathan. I'm going to be speaking about some of the workability issues and maybe possible disadvantages to accepting a policy like this. So the first thing I'm going to talk about is a current practice that accepted is allowing patients to refuse care. This is generally accepted in most situations, and what I'm going to show is that there's a big difference between this and actually assisting them to end their lives. So Robert Weir wrote in a book about physician-assisted suicide, it confuses reality and moral judgment to see an omitted action as having the same causal status as one that directly kills. A lethal injection will kill both a healthy person and a sick person. A physician's omitted treatment, by contrast, will have no effect on a healthy person, but turn the machine off on me, turn the machine off on me, a well person, and nothing will happen. The same action will only bring the life of a sick person to an end because of an underlying fatal disease. So the crucial distinction is that it's the disease that ends up killing this person rather than the actions of another individual, and that's an important thing to keep in mind. And so there's been a lot of arguments about it being the individual's choice to control the end of their lives and their fate. But the issue is that when we accept policies like this, it's really not just them making a choice. By us in enforcing these policies, we're all making qualitative judgments on these people's worth and their value. So in the same book, Robert Weir also wrote, the degree and intensity to which people suffer from their diseases is subjective. Whether they find life more of a burden or of a benefit has little to do with the nature and extent of their actual physical condition. Physical and mental suffering are by themselves utterly poor predictors of a desire for suicide. 3 people, moreover, can have the same grave medical condition, but only one will find the suffering unbearable. People suffer, but suffering is as much a function of the values of the individual as it is of the physical or psychological causes of that suffering. Inevitably, in that circumstance, the doctor will in effect be treating the patient's values. To be responsible, the doctor would have to share those values. The doctor would have to decide on her own whether the patient's life was no longer worth living. And so, moreover, not only does the doctor have to condone these actions and agree to participate in assisting someone in suicide in this legislation, but it also involves the rest of society. If it were a question of suicide, where a person takes her own life without the assistance of another, that principle might be pertinent, at least for debate. But assisted suicide is not that limited of a matter. The self-determination in that case can only be affected by the moral and physical assistance of another. Assisted suicide is therefore no longer a matter only of self-determination, but of mutual social decision between 2 people, and the one to commit suicide and the other technically to facilitate it. Since, moreover, it is presently illegal in most jurisdictions, any change in the law will require the social sanction of a legislator or the courts. That would be a powerful act of legitimation, changing a long-standing set of convictions and laws, and not merely a neutral act of permissibility. So really what I've been trying to show is that by condoning or passing this legislation, we're really changing the way that we view people who are terminally ill and their worth, and that it's not only their choice anymore, because the only reason that they would be able to pursue any of these options is because we've essentially said that we're okay with these actions and okay with these happening. Another issue with the workability is that there's evidence of abuse in Netherlands, and so in a study about the Netherlands, it was written that the official results showed that based on a sample out of a total of 129,000 deaths, there were some 2,300 cases of voluntary euthanasia and 400 cases of assisted suicide. In addition, most strikingly, there were some 1,000 cases of intentional termination of life without explicit request, what the Dutch call non-voluntary euthanasia. In short, out of 3,300 euthanasias, nearly 1/3 were non-voluntary. Unfortunately, there is no analysis or discussion of the 400 physician-assisted suicide cases, but if it is the case that such a large proportion of the euthanasia deaths are non-voluntary, we can reasonably infer that at least some of the physician-assisted suicide cases are involved with some abuse of the physician's power as well. Most likely, the well-placed suggestion and insinuation or a casual attitude towards the patient's competence and psychological state. So I'm trying to show that if this were to pass, that it puts a lot of power in the authority of the doctors, and that with any situation there's always going to be abuses, so we wouldn't be able to really stop people from making these decisions for patients or taking advantage of patients who are having a hard time making decisions about their end-of-life care. If euthanasia or physician-assisted suicide is a viable option because society has condoned it, then more people maybe choose these without fully evaluating the options. So more to that point, Fabian spoke a little bit about palliative care. And so Stephen Dobsha wrote in Medical News Today about people who choose euthanasia or physician-assisted suicide and then change their mind. So one major question raised by the study is why many consider physician-assisted suicide but decide not to take part in it. Explained Linda Ganzani, medical doctor at the professor of psychiatric medicine at the Oregon Health and Science University. There are a number of possible explanations for this. For instance, patients who consider physician-assisted suicide may later dismiss the idea after speaking with their physicians about treatment options which may include better pain control or treatment of depression. Referral to hospice may also affect a person's wishes for physician-assisted suicide. So it shows that even with people who are considering this as options, once they fully evaluate the other alternatives, they can make decisions that maybe this isn't the way they want to go and that they can treat their circumstances a variety of options.